Welcome. In this next presentation, we will be doing a brief overview of the clinical assessments performed as part of the TAB study. The heaviest lift in terms of clinical assessments comes at screening. As a reminder, both blinded and unblinded medical clinicians may perform assessments in accordance with their licensure. While the blinded and unblinded medical clinicians will be reviewing a large number of assessments at screening to determine eligibility, only 2 assessments must be completed by medical personnel: the birth control assessment and the medical and psychiatric history. Please note that if a medical clinician who is not also a physician completes the medical and psychiatric history, that assessment must be reviewed and countersigned by the blinded medical clinician who is a physician prior to the final determination of eligibility. Other clinical assessments, such as vital signs, blood draws, and the collection of concomitant medications, may be completed by either medical or non-medical study staff as allowed by your site, but again must be reviewed by a study medical clinician prior to the determination of eligibility. Let's look at some of these individually. Let's begin by talking about the birth control assessment. Because tirzepatide injections have been found to reduce the effectiveness of oral contraceptives, and because animal studies have raised concerns about potential risks during pregnancy, we need to take extra precautions to ensure that candidates of childbearing capacity are not at risk of conceiving during the study. Therefore, to be eligible, the participant must not be pregnant, must not be breastfeeding, and if of childbearing capacity, they must either not be engaging in or planning to engage in sexual intercourse, or they must agree to use effective contraception from randomization through 30 days following study completion. The study defines what birth control is acceptable. If the birth control used is long-lasting and administered by a medical clinician, such as an IUD, a birth control implant, or birth control injections, then these alone are sufficient to meet the study definition. Otherwise, the participant must agree to use 2 forms of birth control at the same time, such as those indicated here. How will we determine whether or not a participant is of childbearing capacity? If they are cisgender males, then they are not of childbearing capacity. For cisgender females, participants prior to menopause must have been surgically sterilized or have a congenital anomaly rendering them sterile. Postmenopausal cisgender females may be considered not of childbearing capacity if they are 55 or older, not on hormone replacement therapy, and have had more than 12 months since their last period, or are 55 or older and have a diagnosis of menopause prior to starting hormone replacement therapy, or they are 40 or older with an intact uterus, not on hormone replacement therapy, it has been more than 12 months since their last period, and they have a follicle-stimulating hormone level of 40 or greater. In this situation, they must also have a negative pregnancy test at the baseline visit. The medical and psychiatric history captures the participant's current and historical health issues, including surgical history, pregnancy history, and current medications taken. You will want to cross-check the medications reported during this assessment with the medications that were listed on the participant's prior and concomitant medications form. This information is captured on a paper copy of the CRF. And if the medical clinician performing the assessment is not a physician, then a study physician must review and countersign the assessment prior to the final determination of eligibility. A number of eligibility questions appear at the end of the medical and psychiatric history. If any of these questions are answered yes, then the participant is not eligible for the study. Answers from this section of the form feed into the eligibility criteria on the ENRC form. Just a note about question 6 and the issue of gastroesophageal reflux disease. Now that PPIs and other medications for GERD are over the counter, participants may have taken those sporadically to treat self-diagnosed reflux. In order to meet this criterion and be excluded from the study, the participant reporting GERD must have received a formal diagnosis of GERD from a medical provider and must be taking medication prescribed or over the counter on a daily basis to deal with their symptoms. Vital signs will be collected during screening, and they may be performed by any appropriately trained study staff member. This assessment does not require being performed by a study medical clinician. For eligibility, the BMI is the most critical element. Once height and weight are entered into the eClinical system, the BMI will automatically be calculated. Participants must have a BMI of 23 or higher in order to be eligible for randomization. We will be assessing all medications taken by the individual from 30 days prior to consent through the final study visit and documenting those on a paper prior and concomitant medication assessment form prior to entry into eClinical. All meds means all meds. Prescription, over-the-counter, herbal, and other supplements. At screening, we are specifically looking for exclusionary medications or medications that might signal a health or psychiatric problem that could interfere with the participant's safety in the study or otherwise interfere with their participation. At screening, this assessment has a specific question on the paper form to indicate whether or not there were any medications documented. Now, this question does not appear in eClinical. So, if no medications were reported at screening, the paper CRF will be the only documentation of that. Blood labs will be drawn at screening with follow-up labs at month 3 and month 6. At screening, both the eGFR and A1C will be tested, as these have implications for eligibility. The results must be reviewed by a study medical clinician who will review, date, and initial each page. If a result is out of range, the BMC or UMC will sign that result individually and indicate either abnormal or abnormal excludes. Screening labs may be drawn specifically for the study, or if there are applicable clinical labs within 7 days prior to consent, those may be used instead. The A1C is repeated at month 3 and month 6 and may be repeated as clinically indicated throughout the study. There are a number of mental health assessments in the study. The PRISM is an interviewer-administered assessment and is completed at screening only, while the HADS, PHQ-9, and CHRT self-report are self-reported in the ePro system and administered both at screening and during the active study. In the event that suicidality, depression, and/or anxiety are indicated by the participant's responses, a qualified mental health provider must administer the CHRT clinician-rated behavioral module prior to the participant leaving the visit. If homicidality is indicated on the PRISM, the qualified mental health provider will complete a standard clinical interview and take required action as needed. Once screening is completed and it appears that the participant is potentially eligible, they will be invited back to complete the baseline visit, followed by randomization and the week 1 visit, all in the same day. Either a blinded or an unblinded medical clinician will review all eligibility criteria and safety assessments to ensure eligibility, and then meet briefly with the participant to ensure nothing has changed since the end of screening that could impact their eligibility. A specific eligibility checklist and progress note will be completed by the medical clinician making the eligibility assessment, and this must be completed whether the participant is eligible or not. I want to quickly go over some safety monitoring assessments that will occur on an ongoing basis during the study. Note that post-randomization, these assessments are broken up into those done by the blinded medical clinician and those done by the unblinded medical clinician. First, adverse events and serious adverse events. During screening, these are only collected if screening takes more than 1 session to complete. After the first screening visit, study staff will assess for adverse events at each subsequent visit. If an event is reported at screening or baseline, either an unblinded or blinded medical clinician may assess it. Following randomization, only a blinded medical clinician may assess adverse events. Other ongoing safety assessments that must be managed by the blinded medical clinician include those on the screen. In most cases, the initial data will be collected by the RA or RC, with review and management by the blinded medical clinician as needed. In this study, reports of suicidality will be followed up by a blinded clinician who is eligible by licensure to evaluate the participant and take action as needed. While the unblinded medical clinician is free to do any screening or baseline assessments, post-randomization, the only safety assessment they will be allowed to perform is the injection site reaction, which will be assessed at each injection visit. Several of these assessments factor into determining the appropriate dosage for the participant, but those will be discussed in a different presentation. Thank you for joining me for this presentation on clinical assessments. Please reach out to the lead team with any questions you may have. Thanks again.